Okay, hello and welcome to our Ontario Network of CAPC CPNP Projects webinar. Today is January 30th, 2019, and we are here today with Mary Mueller, who is going to talk to us this afternoon about FASD prevention. And Mary, I'll let you introduce yourself a little bit more, however you might like, but before we get to that, I want to take a moment just to introduce myself a little bit. I am the program lead for the Ontario Network of CAPC CPNP projects, and I'm just really delighted to be here with you all. We have people joining us for this webinar from all across the province, and it's really great to see so many folks here and learning together. And before we begin, I would also like to offer a thank you. The Ontario Network of CAPC CPNP projects acknowledges and thanks the First Peoples of the territories where we all work and serve across the province and other Indigenous peoples for sharing this land in order for us to come together in community today. So we take a moment to extend our thank you to our Aboriginal and Indigenous partners. So with that, I am really delighted to hand things over again to Mary. And just a little reminder to the people joining us live today, if you have questions or comments, please feel free to type them into the chat function and we'll get them to Mary at the end of her session. So Mary, how are you doing? Are you ready to go forth with your webinar?
Definitely ready to go.
Wonderful. Well, I'm handing it over to you. I'm going to go off camera right now, but if you need me, just holler.
Thank you, Sydney.
Okay, off you go. Here's Mary.
So it's my pleasure to be with all of you from CAPC CPNP programs today. I worked in CPNP and a little bit in the CAPC program for about 18 years, so it's near and dear to my heart, and I think you're all doing great, very important work. So I'm glad you're here. I am here today from FASD1, which is the Fetal Alcohol Spectrum Disorder Ontario Network of Expertise, and I'm one of the co-leads of the FASD1 Prevention Action Group, and we have some of your members on our group as well. I looked at the list of people that are attending and I recognize lots of friends. So it's great to be with people that I've worked with in the past and are doing great work. And I am not moving forward, Sydney.
Oh, what's happening?
Don't know.
It's not advancing for you?
And let me stop sharing.
Doesn't it?
Whether we want to or not. All right, let's try from beginning. We're moving now. So some of the objectives for today, I just had two. We'll look at the best practices to prevent FASD, and we'll explore perhaps what your role can be in the prevention of FASD, keeping in mind all the many things that you do. Going too fast. FASD Ontario Network of Expertise was formerly known as FASD Stakeholders of Canada. We have a little bit of funding from the Public Health Agency of Canada, and that's sort of what keeps us going. But it is a volunteer collaborative of parents and caregivers, of practitioners and service providers across Ontario. So anyone can join, and there's various different levels of expertise or levels of knowledge depending on whether you're living it or whether you are working with people who have FASD, or whether you're just interested, perhaps your teacher or something, things like that. So some of the goals of FASD1 are, one, to prevent FASD, which is what we're here to talk about today. I don't think we can ever really prevent all of it, but I think we should at least be trying to reduce FASD as well as reducing the severity of it. And the second goal is better outcomes for individuals living with the disability by advancing the development and dissemination of best practices. There are 5 working groups. There's a diagnostic, an education, intervention and support, prevention, which is what I'm on, and a justice working group. And we meet once a month, all the groups, the leads together, to talk about what we can do moving forward. In 2014, we presented a call to action to the Ontario government to do something regarding FASD, and what we would have liked to see was an integrated strategy. But as you know, there has been quite a bit of action in FASD over the last year, and so we're happy to see that we're seeing some action, and so we just need to keep speaking up so that we continue to see action, because I think the action that has happened is good action. We just need to see some more of it, especially in the area of prevention. We proposed recommendations for a strategy: 1, to prevent with evidence-based information, ensure timely access to assessment and diagnosis and services, and then to support children, youth, and adults who are affected with the disability. So those are what the call to action asked for. We love to have new members. You're welcome to join one of our working groups. That's our website. And if you go to the About Us tab and click on Contact Us, just send a little note in there to our chair, Cheryl Neve, and she'll direct you towards the correct action group. We meet by phone every 1 to 2 months, and in the meantime, in between the meetings, we also share a lot of information, so it's really helpful for people to stay up to date. So to talk a little bit about prevention, some people, if you haven't looked at the evidence, thinks we just need to tell women not to drink. And if you've ever worked with women who are pregnant, you will know that that's probably not the best approach. I worked in reproductive health for most of my career, worked in CPNP programs, as I mentioned, for a great deal of my career, and I quickly realized that you can't change everything, and you need to find different ways to get the messages across to people so that it can translate into action. And I think that's the hard part, and we need to think about the context of women's lives and what they're living with and things like that. And I think we learn from the evidence, we learn from the literature, but I do think we also learn from doing. So I feel like a lot of my expertise came through trying some of the things out, and perhaps even making mistakes, and then readjusting to find a practice that worked for me. So I encourage you to do the same. Some people would say, and it's a bit of a stretch, but that FASD is a chronic disease. It's not exactly a disease, but it is a non-communicable condition. It is prolonged in duration, meaning it lasts your lifetime. It does not go away, and it's never completely cured. There will always be deficits, but there's things we can do to help people who are living with FASD. So it is preventable, it can't be cured, and it has one of the health damaging but modifiable behaviors, and that is alcohol. So I think that's an important point to point out, especially with so much energy toward preventing chronic diseases. FASD could be considered that as well. So what's the cost to society? Why are we worried about it? Well, the Government of Canada indicates FASD affects about 1% of the Canadian population. And a recent World Health Organization study found it to be about 2 to 3% of the population. That study was done on school-age children in Toronto, so it's very near to where we are, and certainly residents of Ontario. The 2 to 3% was not alarming to anyone who works in the field, but we haven't seen that stat change on the Government of Canada's site. Perhaps it will, but you do need to be aware that most people in the field now would accept it to be about 2.5 to 3%. The Public Health Agency of Canada estimates that we spend $5.3 billion annually to support those with FASD, and you note it only goes up to age 53. People with FASD do not tend to live as long for various reasons, but many would live past 53, but that's as far as that study took it. CAN-FASD, which is a research network from researchers across Canada, have a researcher by Tan Johnson, and they estimated that the cost is $7.6 billion. So a little higher than the 5.3. You could take somewhere in the middle, but it's costing us a lot of money. And they estimated if we spend $800,000 to $1.4 million per individual is the cost to support them throughout their lifetime. That's a lot of money. And the rate of FASD in Canada's prisons is estimated to be 10 times higher than the general population, which indicates to me that we don't have the correct supports and services for those living with FASD, and therefore they get into trouble with the law and end up in prison. About 60% of people with FASD 12 years and older have been charged with or convicted of a crime. Doesn't always mean that they have done the crime, because many of them will admit to a crime that they haven't committed. 95% of those with FASD have a mental illness, and that's likely because many of them weren't treated appropriately and interventions weren't adjusted to their condition and the way that they learn, and therefore they have things like depression and anxiety and post-traumatic stress disorder, things like that. And CAN-FASD estimates that Canada would benefit a lot if we were to devote resources to the prevention of FASD, because as you can see, it's costing us a lot. And they estimated that if we spent $150,000 to prevent FASD, we would see a return on our investment of $1.6 million. So there is definitely a case to do evidence-based prevention, and I think we need to keep talking about that, and you're some of the people that can do that. So people had asked what were some of the new components that were added to the 4 levels of prevention that the Public Health Agency of Canada developed in 2008. Nancy Poole is the chair of the prevention group with CAN-FASD Research Network, and so they updated the model in 2013, and basically what they added in was supportive alcohol policy. So they looked at 4 levels of prevention that we needed to see action in all 4, and we see action in some of the levels more than others. First one is raising awareness and health promotion. Level 2 is a discussion with all women, and I might add men, of childbearing years and their support networks. Level 3 is supporting pregnant women so that they can abstain from alcohol in pregnancy, or at least reduce the amount. And level 4 is supporting the new mother after she's had the baby, and then looking at child development and assessment if the child has been exposed to alcohol. So the first level is basically level 1, raising awareness and health promotion. Since I worked in public health for about 31 years, I know that we've definitely tried to do this level. It's probably the easiest one for people to do. It is an important component, but changing alcohol consumption patterns is really hard, and just raising awareness probably won't change those consumption patterns. We've seen provincial campaigns, we've seen local campaigns, you've probably even done stuff in your own programs, done some campaigns, and I think you should keep doing those, but on their own, they're not that effective, because people drink for many reasons. Just telling them not to drink, it may not be effective for some people. So what's your role in this level? You should do something, but not just do level 1. So if there are any local efforts in your area for FASD Awareness Month, which is in September, or September 9th to be precise, join in those. Try and take some of them and share some of the messages with your program and your members. Increase your own knowledge and then share that with your colleagues and your agency staff. I'm going to send this presentation. You're welcome to use it with your colleagues and your agency and help them to learn as well. Help to challenge some of the myths that are out there. For instance, drinking 1 drink a day can hurt, well, the evidence would suggest that perhaps it will hurt. But certainly the less is better than more. And so we have to be careful how we share some of those messages, because we have to make sure we understand the evidence so we're not saying something that is incorrect. Post information on your website, your Facebook page, your Twitter account, any of the messages that we would want women who are pregnant and women who are not pregnant to get, so that they can remain alcohol-free if they are to become pregnant. The second level is a discussion of alcohol use and the related risks with all women of childbearing years and their support networks. I think this one, there's been less work in. I see more talk about it in recent years. I'm not sure if all that talk is translating into action, but I'm hopeful that it is. And this is the area that I think we could probably put the most attention on and see a big return on our investment. So evidence would indicate that this is one of the most effective strategies to reduce alcohol-exposed pregnancies. So you're working with women before they're pregnant and you're chatting about alcohol. Health and social service providers are definitely seen as a credible source of information, and their advice is likely to lead to behavior change. So we have some power. In 2009, 43% of women and 32% of women planning a pregnancy in the next 2 years did not recall receiving any information about alcohol and pregnancy from their doctor. That's quite significant that their doctor has never talked to them about it. So if we can talk to them about it, I think it's a really helpful thing, and I do think we have some power. So we need to shift the reproductive lens to preconception, but we do need to remember that we don't want to exclude men as well. I know this just says women, but I think we need to be talking to men because they're 50% of the solution. So, and why do we want to focus on women and alcohol use? Well, if we look at the past year alcohol consumption for women, you can see in 2010 it was 74.6, 2011 78.9, 2015 76.7. So we are bouncing up and down, but on the whole we've gone up. And if we look at those that might be drinking more, about 17.1% reported exceeding the low risk alcohol drinking guidelines for women. Daily drinking rates for women increased from 2.6% of women in 2001 to 5.8% in 2015. So women are drinking more on a daily basis. Hazard or harmful drinking for women increased from 4.8 in 1998 to 8.4 in 2015. So we are drinking more regularly and we're drinking more at a time. And binge drinking rates for young women have increased in the last decade. But recently we've seen a bit of a decline, so I think some of our efforts might be paying off. This is some new research that I hope you can perhaps have a look at when you are off this webinar. It's called Doorways to Conversation. It's a brief intervention on substance use with girls and women. It was completed, this research, by the BC Centre of Excellence for Women's Health, and the link is there. It's an excellent resource, and basically what it looked at is, for level 2, often people thought they had to screen women. And if screening is working for you, by all means screen. But what this research found is that brief conversations that are non-judgmental, casual, short, may have as big an impact as doing a screen, and perhaps more, and help to open up the door to chat with women about not only their alcohol use, but their context of their alcohol use. For instance, perhaps they're have some mental health issues, perhaps they're being abused at home, perhaps they're using other substances. So the casual, brief conversations really do make a difference, and these are the things that I think you're doing in your programs anyways. So I encourage you to keep doing that and to find opportunities to chat about alcohol and what we're worried about with women. And we're not just worried about them drinking in pregnancy. Again, think about the woman and her whole context. Alcohol does affect women differently than men because we have more fat and less water, and because of the enzymes we have. Less alcohol for us can affect us just the same as more alcohol for men. So basically, if women drink the same amount as men, that we will see more of the difficult effects that we don't want to see with alcohol. So it may increase the risk of chronic disease such as cancer, breast cancer, stroke, heart disease, certainly violence, and also injuries. Risky use of substances before pregnancy puts a woman at higher risk of alcohol use in pregnancy, and FASD is basically caused, as you know, by alcohol use in pregnancy. If we wait to prevent FASD in pregnancy, we're really too late. So we really do have to start talking about this to all women and men of childbearing age. So the rate of unplanned pregnancy is about 40 to 50% in Canada. Women that are at the highest risk of binge drinking, which we feel really has an effect on FASD, the binge drinking, is for 15 to 19 years of age, followed closely by 20 to 24. The highest rates of unintended pregnancy are in the 15 to 19. So if they're binge drinking, they're not planning on getting pregnant, they might be not using birth control, so they're at risk of having an alcohol-exposed pregnancy. And 82% of pregnancies in the 15 to 19-year-olds didn't plan on getting pregnant. In 2009, the Canadian Maternity Experiences Survey found 62.4% of women drank 3 months before pregnancy, and 10.5% reported drinking in pregnancy. Incidentally, I was just looking at something about Scotland and the UK, and they estimate that 40 to 50% of women drink in pregnancy in that country. We're probably not that high, but I would suggest we're probably higher than 10.5% because we didn't actually measure if women were drinking, we just asked them. So certainly be familiar with Canada's low risk alcohol drinking guidelines. Talks about there what is a standard drink. You can Google these online, but basically the low risk alcohol drinking guidelines for women are no more than 2 per day and no more than 10 per week. And you can't add up all those 2 per day and drink them all at the same time. Should have some, for men, 3 per day and 15 per week. Should have some non-drinking days every week so you don't make alcohol a habit. And they do make exceptions for special occasions, which is to reduce your risk of injury and harm by drinking no more than 3 drinks in a sitting, basically to reduce risk of injury, violence, unplanned pregnancy, but that would be occasional. The other message that's in here is if you're pregnant, 0 is the safest. And this is what they say: if you're pregnant or planning to become pregnant or about to breastfeed, the safest choice is to drink no alcohol at all. What I wish they had to put in here was that if you think you might be pregnant, please stop having alcohol. Because a lot of women will continue drinking until their pregnancy is confirmed. So I think it's important for us to get those messages out there. There are many different target groups that require different approaches. And basically, we would suggest that one of the target groups is all women and men in their childbearing years. FASD does not discriminate. It affects anybody from any socioeconomic background, religion, culture, race, and age, which is different than tobacco. Tobacco we would see more in women struggling with the social determinants of health, and opiates the same. But alcohol, we see it across all types of people in our society. But we do think that there are people that are struggling with social determinants of health require a different approach than perhaps a woman who is in a career and has some good income. The approach would be different. And that might be, if you're struggling with social determinants of health, how can we get her more support so that she's not stressed all the time? And that might decrease the risk of drinking above the low risk alcohol drinking guidelines. We might get some help with mental health issues. Things like that could really make a difference for that target group. Another target group that might require a different approach are women who are working in a more established career, and they've waited until the career was more established to begin a family. By then, perhaps some of their drinking habits are solidified in their life, and it might be more difficult for them not to drink if they're planning on getting pregnant or when they do get pregnant. And it is really important, one of the target groups, to address the partner's substance use and their support network substance use, and how can we approach those. So what are some of the strategies for women and men of childbearing years? You can screen, you can do brief intervention or brief conversations, and if there are concerns, offer a referral to an addiction treatment center or some online resources. Whatever suits that woman the best might be something that you could do. You should start before pregnancy if you can. So that's why some of these conversations should be happening in the CAPC programs after women have been pregnant, because we know that they may be pregnant again. Having brief conversations and screening all women for substance and alcohol use. Up in the news, and for instance, that one document, the brief conversations, if you look in the back of it, it has some fact sheets for different substances and the effects they might have in pregnancy around perhaps alcohol, cannabis, tobacco, opiates. And so you can give those messages. Provide the key messages to all women regarding Canada's low-risk alcohol drinking guidelines. There's a website, rethinkyourdrinking.ca, done by some of the health departments, public health in Southwest Ontario. And basically, you could give that website to some of your women, and they can check out their own drinking and learn that way, not just by you chatting. Emphasize that the low-risk alcohol drinking guidelines are and if you don't, you know, we discuss this with all women because we're concerned about the effects alcohol might have on their health, and concerned about the effects might have on a pregnancy. And open-ended questions really work well. I really like this one. How does alcohol fit in your life? Then women really are pretty honest, because we don't make them feel targeted. We don't make them feel defensive. They can answer however they want. And I really like that question. I have used some of these screens, and I did not find they were very helpful for me, but some people do find them very helpful, which is why I put them up here. But I would be practicing brief, informal, comfortable, safe conversations with all women. And some of the screening tools that you might want to use are CAGE, TACE, CAGE, Tweak, the Audit. If you're comfortable with any of those, please continue to use them, and maybe just try a few more things in your practice. And I think it's important for us to assess if they're following the low-risk alcohol drinking guidelines. If they're above the low-risk alcohol drinking guidelines or they screen positive, advise them to cut back, advise them to be using birth control to prevent a substance-exposed pregnancy, and if they're willing, offer a referral to a local service or online phone support, one to maybe get more information if that's all that they want at that point, or to get some help if that's what they want. But it's important that the women lead that action. We just offer it in a very respectful way, and if we are concerned, we say what we're worried about, and here are some services that might be helpful. If they're using alcohol and substances, it might be helpful to assess how often, how much, why they're using them, and what their self-perception of their use is. Some people don't think it's a problem, and it's our opportunity then to perhaps give one key message. I think you can overwhelm people with messages regarding your concern about alcohol use and a potential pregnancy, and on the woman's health as well. We could refer them to telehealth. There's a drug and alcohol helpline. Center for Addiction and Mental Health has services. Also, Mother Risk number is there, and you can have them call there. I think it's important, again, to discuss birth control that they might want to use, that they would use every time to prevent an alcohol-exposed pregnancy. And keep in mind, we are recommending multivitamins for all women of childbearing age. And the reason why I suggest that is we do know that proper nutrition can make a difference to decrease some of the effects of alcohol. It certainly won't hurt. And I would encourage you to find out about your local services, what supports and programs are available in your area. And if you don't know, start looking online and making some phone calls and be familiar with those services so that it's easier for you to refer women. Remember, supports can be other than addiction services, might be helping them make their life less stressful by helping them to get access to free food or free clothing or free equipment or support, and figure out how you can refer the women and men to the programs, and make a point of getting to know other service providers. I know when I first started in my career, I found that quite intimidating, but the more I did it and the more I got on the phone and chatted with some of the other services, the better we functioned together. This is a poster we did at FASD 1, and the whole point of this poster is to address level 2 and to encourage healthcare providers and social services to be, we almost all ask about birth control use, but at the same time talk about alcohol use. And we know that if we do that, and we can reduce the rate of alcohol-exposed pregnancies greatly. And I think that's important for us to do. So don't forget to talk about alcohol with birth control and birth control with alcohol when you're working with women of childbearing years. We also have a French poster for those who speak French. I don't, but I do think that the translation is correct. One of our French-speaking members did it. Some of the strategies, again, this is developed by CAN-FASD to reduce substance use, and things to keep in mind when you're chatting with women of childbearing age is we want to be respectful. We want to build a relationship with the woman so we can have that conversation. We need to remember that women are determining what actions they take and not us. So we need to plant the seed and let her take the lead. That we not just talk about alcohol, we also talk about her whole health and her whole well-being. We need to be accepting of harm reduction approaches because that might be the best we can do with some women. We need to be respectful that some women may have had trauma in their past, and we may need to deal with that if we want to reduce alcohol use. We need to be promoting their health and thinking about their whole health and not just around alcohol. We need to make the discussion culturally safe for women, and we need to be supportive of mothering, and for them to be a mother in whatever way that might be. And we also need to think about a disability lens. Some of the women we're working with may actually have FASD themselves that's not diagnosed, and therefore we need to be very concrete, and we may have to help them follow through on things because that might be very difficult for them. So what's your role in level 2? Discuss alcohol use and the risks with all women and men of childbearing years and their support networks. I think the safe conversation is important. Provide the key messages regarding safer alcohol use. Discuss birth control in relation to alcohol and other substances, and link to services if needed. And I think that's something that we can all do. Some of us may have more time than others, but do what you can. The third level is level 3, and this is basically working with pregnant women and their support networks to, if possible, not drink alcohol or at least reduce. So there's quite a lot of specialized supportive pregnant women around alcohol. There's addiction programs specializing in services for pregnant and parenting women. They take on different forms in different communities, so again, you need to be more familiar with your services. I will say, though, that in some small rural areas, you may not have that service, and actually in some medium-sized cities, you may not have that service. So I keep advocating that we need to have those types of specialized services for pregnant women that are struggling with alcohol and substance use in every larger center or somewhere in your region that's accessible for women to attend or take part in, or be able to use the services. So I think that's really important, and I just keep advocating for that. I know in Kitchener we have some services, but we don't have the same, for instance, as Toronto. There are regular addiction services, may be good for some pregnant women. Connects has some really good resources online, and they might be able to direct you to a program in your area if you're not familiar. Don't forget about Healthy Babies, Healthy Children. It's a one-on-one support, and they can help pregnant women as well, so be sure to be referring to that. Often family and children's services are involved, and when I worked with women who are pregnant and struggling with substance use, I try to talk about family and children's services as a support that will make it easier for women, one, to parent, and two, to remain alcohol-free. Canadian prenatal nutrition programs, I think, are huge supports and do some really good informal work with women who might be at risk of substance use. There are places, as I said, providing support with housing and food and equipment. There's Mother Risk is another good place to direct women to if they only want to accept phone support. And some women prefer to go outside of their region for treatment because they don't want people to know. So again, you might have to reach out to another health department or another CAPC CPNP program and find out what is available in that area. Keep in mind that if they are going out of province or out of country, there is a fee for those. So what's the outcome of prenatal substance use exposure on babies and children? Well, the impact of the alcohol on the baby in utero will depend on when alcohol is consumed. So was it consumed early on? Was it consumed later on? What was developing at that point in time will determine what the damage looks like. How much is consumed? We know the more that's consumed, the more damage, and the more that's consumed at a time, the more damage, and how often it's consumed. Some of the research would indicate it may also depend on age. Women may not metabolize alcohol the same when they're older, and they may have already had some alcohol-exposed pregnancies, and those children appear to be fine, and therefore might be more likely to drink more in subsequent pregnancies. It may also depend on how well they ate. It may also depend on whether they have other stresses in their lives, which would include the determinants of health. And certainly there is a lot of research on some people metabolize alcohol differently, so it could be genetic factors. But the important messages are to get out to women is that the brain develops throughout pregnancy. So it's not just if you drink alcohol at the beginning of your pregnancy that we're concerned. We're concerned throughout pregnancy alcohol use because the brain is developing for the entire 9 months. And that we need to get through to people that it is an invisible disability for the most part because the disability is inside the brain. So that's the concern. Risk factors for alcohol use in pregnancy. Well, everyone is at risk, but some people are more at risk than others. So people who drank above the low-risk alcohol drinking guidelines before pregnancy, you should be chatting a little bit more with them. They might have had pre-pregnancy binge drinking, again, perhaps even more at risk. Women who weren't using birth control reliably are more at risk because they may have stopped drinking after they became pregnant, but the baby may have been exposed early on, so they're more at risk for having an alcohol-exposed pregnancy. Women who are older and who have been in a career perhaps and have drank socially may have continued to drink because that has been their pattern, and people might ask them if they're pregnant if they stop drinking. Low socioeconomic status may put women at risk and may, because of the other risk factors there, such as low income lower education, perhaps more stressful lives, just add another layer that might make it so that the baby is even more at risk. If you have a partner who drinks, more at risk for alcohol use in pregnancy, and that's why we need to address the partner as well. Mother with cognitive impairments may be more at risk because she may not understand the long-term effects or may not be able to put them into practice. Women with mental health issues, mothers using other substances may be more at risk of using alcohol in pregnancy, and having a previous child who was exposed to alcohol, as I said, who may not seem like there's anything wrong with them, may make it so that women might be more likely to drink in pregnancy. What's the prevalence? As I said, about 10.5 to 11% of women consumed alcohol in pregnancy. It's more commonly reported in older women. I just let you know that tobacco use in pregnancy, about 13% of women smoke cigarettes, so that's fairly comparable. Tobacco use in pregnancy is more common in younger women. Illicit drug use, about 5% of women report illicit drug use, so you can kind of compare the substances. I'm sorry, I don't have cannabis here, but cannabis probably around tobacco or maybe a little higher, and it will change depending on the age group. So I think that's really important. Those under 30 are more likely to use cannabis in pregnancy than those over 30. Underreporting is an issue in pregnancy because it's very scary to report that you're using alcohol in pregnancy because of the social stigma and the concern that their child may be apprehended. And you would assume that if they're using illicit drugs that they might also be using alcohol, and they might have poor eating habits. So substance use in pregnancy is really not simple as tell them not to drink, because 2/3 of people with substance use problems also have mental health issues, so we need to be assessing for that. Many women who use substances also experience physical and sexual abuse. So again, we really need to assess for those three things together: substance use, mental health issues, and abuse. It's not as easy as just telling women don't use alcohol substances. We need to assess, provide support for women to access services and not just addiction services, and mental health issues and abuse. Excuse me. So advising women to stop substance use in pregnancy may help light users, but those using substances to cope might need a little bit more support and more service. So strategies in pregnancy are practice asking and referring, or having those brief conversations. I know that the more you do it, the better you get at it. Think about having those conversations multiple times throughout pregnancy, not just once. Encourage all women to stop alcohol and substance use throughout pregnancy. That should be one of our key messages. And if she's unable to stop, encourage her to drink less. We need to try very hard to be non-judgmental. That's why I really like that question, how does alcohol fit in your life? And be sensitive to the fact that maybe no one's asked them that, and maybe this is the first time she's shared with anyone. And if she has shared with you, she has done you a real honor, because she obviously trusts you, and you need to be sure that you continue to ask about it and to help her access services that she's ready to access. Discuss the effects of alcohol substance use on the developing baby with all women. Refer to mother risk if more information is needed. And I think it's important to acknowledge that many pregnancies are unplanned. 50% are. And that many of them might have been consumed substances before knowing about pregnancy. But we can only start where we are. And if the woman has stopped or cut back, I think it's really important to encourage that behavior, compliment her, tell her how strong she is, and what can you do to help her maintain that change in her behavior so that she has a baby who either has no more exposure to substances or has less. I think it's important not just to focus on the baby as well, but to focus on her, and that she's worth it, and you know she can do it with some support. And offer to help her with those referrals. Include her partner if the partner is there and they are willing. And as I said, support can take many forms. It could be even just giving prenatal vitamins or helping her to access those. Sometimes your role may be harm reduction, and some people struggle with that, but that might be our role. And if that's as far as she can come, then we've done a good job if she's able to reduce. Alcohol and crystal meth are the substances that we are aware of that causes the most permanent harm to the developing baby. And I don't mean that other substances don't cause harm, but we do know that these two affect the brain development. Be sure to thank her for sharing and encourage her to come back and talk again, especially if the conversation has gone well, or she may have some friends you might want to encourage to come back. If you have someone you think that might have FASD, keeping in mind most people are not diagnosed, so these would be women who can't show up for appointments on time, don't follow directions very well, can't find their way in the bus, forget what day it is, things like that. But sometimes they talk well. Be sure to be thinking about perhaps they might have FASD and might need some more support to follow through on things. They might have had trauma in the past because of their disability and their disorder, and therefore that affects how they process things as well. We may need to talk about harm reduction, and we need to think about culture and how we might approach these women depending on what their culture might be, and make it safe for them to chat about their potential alcohol use in pregnancy. So what's your role? We'll ensure that women and partners at risk of using alcohol substances in pregnancies are connected with support services. And I think CAPC CPNP programs do a great job with that. Provide the key messages to all pregnant women and their partners. Be prepared to take a harm reduction approach if that's all the woman is ready for. And include the women's support network if possible, because they will influence her behavior greatly, and not just her own behavior. So it's really important. The last level is support for the new mother and child development and assessment. And this is level 4, and this is basically working with the woman after she's had her baby. For this, you need to be talking about birth control, so we prevent a future alcohol substance exposed. Refer the women that have had a baby who is alcohol exposed, no matter how much, no matter when, to infant and child development programs. I know in our region, they're seeing all babies that are substance exposed. Even when they're born, they seem like they don't have any problems, and we may see some of those problems later on. And the earlier the intervention, the better the outcome would be for the child. Refer the families to HBHC, or Healthy Babies, Healthy Children, and other developmental services in your region. Get them going to Ontario Early Years Centers and community programs. Family and Children Services, as I said, can be helpful, and they're often involved, and I always found it very good to work with them as a CPNP worker and try and help the woman to see them as a support, because they're not always seen as a support, because women are scared because their child might be apprehended. So what's your role? Ensure the baby's being followed by appropriate services, such as infant and child development programs. Ensure the new mother has supportive parenting services. Support the new mother to remain alcohol substance free. Discuss the effects of alcohol and substance use on breastfeeding, and ensure the new mother has access to reliable birth control. The middle of the model looks at supportive alcohol policy, and I don't think all of you will be involved in this, but all of us have a voice, and we should be speaking up. And these are sort of, you need to ask yourself, where can you make a difference? Alcohol policy will benefit not just pregnant women, but it will benefit everyone in our society, but especially those who drink in an unsafe manner. And it may reduce the overall harm from alcohol and reduce the incidence of FASD. Things that can make a difference are making it so that alcohol is not as physically available. For instance, now we have it in grocery stores, it's more physically available. And that's a policy where we saw increased access. And from an alcohol perspective, that's not what we want. Control affordability, make sure we're increasing the costs of alcohol so that it's not as affordable, and so therefore people usually use less. But we do need to think about them, perhaps if they're really addicted to alcohol, maybe they're using some more harmful substances as well. Place restrictions on marketing, develop drinking and driving prevention countermeasures, modify the drinking environment so that we have to talk about social constraints and sort of changing our culture around that. Develop education and persuasion strategies to encourage people to decrease drinking, and provide treatment. So the legal drinking age does have an effect on alcohol use. So Ontario has 19, some of the other provinces are 18, and the 19-year age does make a difference with the amount of alcohol that's consumed for those in their teens. And if we know that people start consuming alcohol later in life, that they're less likely to have an alcohol problem later on. We could create a policy that mandates universal screening, brief interventions by primary healthcare providers. We could limit the availability of alcohol. I'm concerned that alcohol might be sold in convenience stores like it is out west, and we need to advocate that that not happen, because we know that if it's more available, we're going to see more alcohol use. We need to advocate to limit the alcohol marketing to youth and women of childbearing age. Support things like Sandy's Law, which is that wherever alcohol is sold, there has to be a message around the risk of alcohol use in pregnancy. And we need to advocate for a provincial alcohol strategy. Ontario does not have one. It was promised with the last government, but we do need to keep advocating for this, because alcohol is costing us a lot of money, not only in FASD, but in cancer and chronic diseases, and in motor vehicle injury, and in violence as well. So if you work by yourself, moderately effective. If you work together with other resources and other services, it's going to be more effective. If we evaluate our success, even more effective. But if we develop policies that will limit the use of alcohol, that's the most effective, and limits ensure all women and men are screened or have brief conversations for alcohol use. Again, those policies would really make a difference. Thank you for listening to me talk. I always find webinars hard because I like to be interactive, but I think we've gotten through the information. Somebody did ask before, where can they get help for those who might be living with FASD? And I would encourage you to look for your FASD support worker within your region. You should have one by this point, and if you don't, be looking for FASD support workers on the government website, and hopefully can find one in your area. So thank you.
Thank you, Mary. Hello. Oh my goodness. Wow. What just an amazing scope of information that you've provided for us. I don't see any questions that up in the chat. So if you do have something, please feel free to type it in there. We have just a minute or two left in the session. I will say that a couple of things really struck me as I was listening to you, Mary, and certainly the difference between a screening interview and a casual conversation. I think that's such an important distinction to make. And if we had more time, I'd like to dive deeper into what those two things look like. But I think you gave us a really good framework to think about. I also think you mentioned just having a key message in your pocket to not overwhelm women with information, and I was kind of curious what that would be. But then you did suggest a little further that perhaps, I want to see if this is. If you agree that key messages are that the brain develops throughout the pregnancy, like that's sort of one key message, and the other one being the that it's an invisible disability. Would you agree those might be a couple of key messages?
Yes, for pregnant women.
Mm-hmm.
For women who are not pregnant, I think the key message needs to be talking about their current drinking habits and ensuring that they're using birth control
Right.
to prevent an alcohol-exposed pregnancy. But Yes, I think the more informal the conversation can be and the less judgmental, I think you just develop that as you practice. And I can tell you, I wasn't very good at it at the beginning. And I just kept trying to implement open-ended questions, talking at the beginning of the conversation that I talk about this with all women. This is why I talk about it. What questions do you have? Things like that. Just really let women sit back in their seat and have a casual conversation, which is going to be listened to better than a preaching conversation.
Absolutely. Absolutely. I wholeheartedly agree. So that is our time today. I want to thank you, Mary, so much for taking the time to join us and sharing your wisdom and your experience. And for those who have joined us live here today, there's quite a few people and reading lots of positive comments in our chat of people being very grateful to Mary for her time and sharing her knowledge. I want to invite everybody to make sure to join us for our next network webinar, which is on February 21st, where we're going to be looking at using the tool of social media in our projects and programs and how that can be a tool for outreach. So don't think you want to miss that one. You will see ways to sign up in the newsletter on WebConnects, or you can always send me an email. So with that, I wish everybody a wonderful afternoon. Stay warm wherever you are. And again, thanks so much, Mary, for joining us. And I hope our paths will cross again soon.
And I just want to thank all the participants. You're all doing great work in your CAPC CPNP programs, and it's such an unrecognized resource. But I know how helpful it is to pregnant women and women who are parenting. So keep up the great work. You're doing wonderful work.
Thank you, Mary. Take care, and we'll talk again soon.